Hello everyone and welcome to CK Med. My name is Clark and I'll be taking you through lipoproteins and hyperlipidemia disorders today. So to first start things off, we need to understand what are lipoproteins and how do we kind of find them. And so what lipoproteins are pretty much are packaging molecules that carry triacylglycerides, which are your tags, and your cholesterols and cholesterol esters, and they kind of carry them around in the blood. And they're organized from very large molecules like the chylomicron to very small molecules like the LDL and HDL particles. And so I wanted to kind of organize you to how we're going to be going out throughout this whole PowerPoint and describing some of the diseases. You have to have in mind this order. Okay, so to first start things off, we need to understand how digestion works. So you take in a big giant meal, maybe a big juicy burger or something like that. And after you digest it and break it down a little bit in your stomach, it goes to your small intestines. And your small intestines have an epithelial cell type known as an enterocyte. In your enterocytes, what happens is some of the enzymes, especially in your duodenum, activate pancreatic enzymes, and those go to activate and form your micelles and other things, break down your sugars, so you can get them into smaller particles and absorb them into the enterocytes. So for fats examples, we use bile, and that esterifies the outer coat of each of these particles and allows some enzymes to break down your triacylglycerides and other fats into smaller fats, free fatty acids and smaller fat molecules. Then those get absorbed through the enterocytes, and now they're inside the cell. And before they go anywhere from the cell, what they actually have to do is they actually have to make a molecule known as a chylomicron. And that's the first large lipoprotein that we're going to encounter. And so I want to emphasize that this is the first thing that you encounter after you take in that giant meal. It also is the largest molecule. We just took in that big giant meal. We have to store it in a large giant lipoprotein. And so what we do is we package this all up in this giant thing, and then we attach a key to it. So we attach this little key to it, and for this one we'll be describing exactly what that is in just a few moments. But once this goes in, it makes its way to the liver via the portal and lymphatic system, and then makes its way into the liver and gets absorbed. Well, it gets cut down to smaller molecule into a remnant and then gets absorbed in the liver. And now whatever remaining tags and whatever molecules is left in there gets packaged up into a molecule to be shipped out of the liver, and this is known as your VLDL. So VLDL are very low density lipoprotein. This is your next in line as far as size and in order. So it's the second largest molecule that you do make. That is a lipoprotein, and it is the second in line from this order. So first was chylomicron, then second was VLDL. So VLDL goes out to the periphery, and it gets secreted out from the liver, and it goes out to your muscle cells and your endocytes and endothelium and such like that. And what happens is those locations have an enzyme that cuts out some of the fats from here, and it makes it a little bit smaller. And when it makes it a little bit smaller, this molecule is now called IDL, or intermediate density lipoprotein. And so what happens here is this guy can actually get absorbed straight back into the liver, or it can continue to get cleaved into a smaller molecule known as LDL. Now LDL, I'm sure you've had, this is your lousy density lipoprotein, so that's the lousy one, it's the bad one. This is the one that causes atherosclerosis and such like this. But this molecule can continue and can be made into even a smaller molecule known as LDLB, which we'll be discussing at the end of this PowerPoint, or this is just going to get absorbed from the peripheral cells or from your liver. And all these molecules require certain Apo proteins for activation and such like that when it gets to certain places, but we'll be describing them later. Then we have our healthy HDL, which is actually the smallest of all our guys. But this guy works in taking fats in atherosclerotic plaques and from the tissues and actually bringing it back to the liver. So it's kind of the cleanup guy. And this is your good or healthy density lipoprotein, or HDL. Just remember that we have size pretty much goes down this way, but the densities actually go in the opposite kind of direction. So how this works is the ratio, the density, and what we're describing density is what is the density of cholesterol to tags or triacylglycerides. So our chylomicrons and our VLDL actually have tons and tons of tags. Our VLDL is pretty much marked mainly by your VLDL number, and this is pretty much your triacylglycerides, and you have very small amount of cholesterol in relevant amount. And so that ratio of cholesterol to tags would actually be very, very low, and that's why we call it very low density lipoprotein. But as you move this way, you actually start to cleave off those tags and leaving the cholesterol within there, and now your cholesterol is actually relatively higher compared to here, because this is actually, the tags are actually what's decreasing, so the denominator is actually shrinking in size, making the numerator seem a lot bigger. Therefore, your density actually increases from very low to low, and then high density lipoprotein, or HDL, actually has almost all cholesterol, or packaged cholesterol as cholesterol esters, and we'll be describing each of those. So how we kind of separate each of these guys is based on their little particular key molecules that they have, those little keys that they got. And each of them have their own kind of specific one or specific arrangement of them in combination just to the molecule size itself. And these are known as apolipoproteins, or apoproteins. And this is actually what determines on electrophoresis what is going to kind of travel along the electrophoresis is what apoprotein it is and how much of that apoprotein, and that will determine how far it travels on here. So here we had the centrifuge. So if we centrifuge it, it would be large molecules on top, and that would be kind of your milky stuff, that's chylomicrons. And then at the very bottom we have our little sand particles, if you want to think of it to giant rocks and pebbles versus our giant sand, or tiny sand particles. They kind of centrifuge all the way down to the bottom, and that's why it's in this order that we have found here. But on electrophoresis, it's based on charge, and what are those? And so the more of these apoproteins, the further it actually travels towards the anode, towards the positive side. Remember, proteins are negatively charged, so they're going to be repelled from your negative charge input on this side and be pulled over towards your positive output over here. And so the first guy that we have, and that's not going to travel very far, is we have chylomicrons. So chylomicrons are huge particles, so not only by size do they not want to travel, but also they only have a few ApoE proteins. Pretty much all it needs to do is get chopped up a little bit small in the periphery, and then it only needs a couple keys in order to enter into your hepatocytes. And so it only needs a few of these ApoE proteins. So when you only have a few, it doesn't travel very far. It also has B48, but again, it only has a few of those. B48 is required for chylomicrons in order for them to actually leave the enterocytes into the lymphatics, and then that's going to go into the blood and then back to the liver. So ApoB48 is actually what allows that to leave those cells. LDL is another guy here, and this is actually the next one to be traveling along here. We have lots and lots of B100. So this is an apoprotein, which we'll be describing in just a little bit, but this is found on LDL, and it has a ton of those. But that is all it has. It has a ton of ApoB100, but that is all that it has and needs. And so it only has one thing that is actually in high amount on its surface, and therefore that's the second thing to travel. VLDL has not only a lot of B100, but it also has ApoE, and so when you kind of combine both of those together, it has, say we have 100 particles of ApoB100 on this one, and we have 100 of B100 and 100 of ApoE. That's 200 apoproteins on the surface, allowing for them to actually have a greater force to travel further. Electrical force. And so that's why here it's actually not in the correct order from size like we described in the last slide. So it goes chylomicrons, LDL, then VLDL, and HDL. And I want you to be very careful with that. I want you, if they have a picture of electrophoresis, you need to be able to read this correctly and diagnose it, because they might be presenting you a vignette of someone and they said, oh, here's electrophoresis. What's their diagnosis? You need to know that as far as an electrophoresis, the LDL and VLDL actually go out of order. So watch out for that and be careful, okay? They really like that, so that's very high yield. Next, HDL. It's so tiny, and it has a ton of apoproteins. It carries all the ones it's going to give to these guys in the circulation, as well as its own. It has alpha apoprotein and stuff like that, and that's why HDL, being that it's very small, plus all those apoproteins, it travels the furthest on electrophoresis. All right, so what are these apoproteins? Let's describe them a little bit. What are the specific ones? So the big and high yield ones that you definitely need to know are ApoB48, 100, E, and C2. And so ApoB48 is actually what is found on the surface of chylomicrons only. It's the only one that that carries ApoB48. And what puts this on is actually this enzyme known as microsomal tag transfer protein. And if you actually are deficient in this, we'll be describing this disease later, then there's no actual putting of chylomicrons into the blood, and so we're actually not absorbing our fats correctly. And so that's going to stay in the lumen of your GI tract, and when you have lots of fats, that leads to like stinky, floaty poop, steatorrhea. So the next apoprotein we're going to discuss is ApoB100. So ApoB100 actually is the exit key for VLDL from the liver. Remember, the liver secretes VLDL, and it requires B100 in order for it to get out. If you don't have B100, VLDL cannot be secreted from the liver. So you're going to have low tags in the serum. But usually that's not a problem, and so these guys are going to carry B100, and then remember you get cleaved into IDL, and IDL also carries ApoB100. But it loses it on its way back to the liver, and it loses it when it turns into LDL as well, when it gets cleaved a little bit further. Or IDL specifically loses it, but LDL actually, this is what is required. This ApoB100 is required from LDL in order to be uptaken into the liver. So not only is it to be secreted out as VLDL, but also to be uptaken as LDL specifically in the liver. Remember, IDL is not the same particle. So ApoE, so this is E for entrance of chylomicrons and IDL, and so that's what IDL actually is reliant on in order to enter into the liver cells. And then ApoC2, and this is for cashing in of your tags to peripheral cells. So this apoprotein is actually required from the peripheral cells, because it has this enzyme known as lipoprotein lipase, and it needs to be activated. So we learn about cofactors, some of your biochemistry modules, some of the vitamins and stuff like that. But this guy, as far as fat cutting up, this requires ApoC2 on your lipoproteins in order to cut those guys up, and that's a lipoprotein lipase. We'll be describing that. So lipoprotein lipase, that enzyme I was just discussing, and what happens is found in different tissues. And so in the heart, there's no need for insulin. The heart is constantly beating, and so it constantly needs nutrients of glucose and fats and stuff like that. And so we want to make sure our enzymes don't require insulin in order to function. The second, if we become insulin resistant or insulin deprived for some strange reason, maybe type 1 diabetes or something like that, then that person would die very, very quickly because of heart failure if this was the result, if our heart required insulin in order to get this in. So we know that our heart does not require that. But in adipocytes, however, this does need insulin, because adipocytes aren't really that fantastic. They're pretty much just storage molecules of fat, and we know that. And so we need insulin to keep that regulated on them storing. And insulin, remember, is in that postprandial state, and so that's going to be having tons of energy, and tons of energy is when you need to be storing your fat in your adipocytes. So that's pretty much, it makes sense that everything's occurring at the same time. I just ate, I have lots of insulin, I'm going to be storing things as fat. Well, duh, that means that in fat cells, we need insulin to bring it in, or the lipids in, and so it totally makes sense. So the purpose of this protein, what it does, it actually, these lipoproteins, remember, they're carrying tags like VLDL. Let's take VLDL, for example. It's a very high amount of tags versus cholesterol. And these tags are very large molecules, and your cells can't absorb them that way. They actually have to cut them into smaller molecules, then they get them in through the door, then you can remake them. And in order to do that, you use this enzyme, lipoprotein lipase. And what happens once you cut tags, you make free fatty acids, and then those free fatty acids and glycerol, because that's the backbone for our tags, get reformed once they're inside the cells. Our molecules, such as your LDL and stuff like that, also can be oxidized, and our free fatty acids can be oxidized into energy and acetyl-CoA that can go into your metabolic pathways, which you'll be kind of going over in term 2, so I wouldn't worry about it too much right now. Just know that in adipocytes, there's insulin required, heart there's not. LPL is the thing that's cutting into free fatty acids, and in order for everything to get into those cells for storage. A little bit of biochemistry further beyond this. So in adipocytes, in order for them to take in the glycerol and the free fatty acids and then rebuild it into tags, it actually needs a glycerol triphosphate, which is floating around in the blood from the liver, and we have to take that triphosphate form. The adipocytes do not have the ability to convert just a basic glycerol, phosphorylate it 3 times, and then that allows us to stick fats on it. It's just, there's no enzyme for that, and so it actually needs that glycerol triphosphate for it to work. And so that's specific in your adipocytes. In your heart and other tissues, we're pretty much going to take those free fatty acids, we're going to cleave the tags, get the free fatty acids, break them down, so then we can oxidize them and make acetyl-CoA for energy, and that's exactly the purpose of those tissues. In the liver specifically, however, the liver is the one that takes basic glycerol and it actually triphosphorylates it, allowing for storage of fats in the liver cells in addition to secreting that and giving it to adipocytes so that they can store more of the fats. But it also allows for beta oxidation in the liver of those free fatty acids, and then we can actually reship it and put it into VLDL to spit it back out. So here the order, I want to emphasize this order again down at the bottom. We're going to be going through each of these and explaining each of them, and hopefully all these make sense once we get to the diseases, what's happening. So the first molecule or lipoprotein that we're going to get to is the first one that we see in circulation coming in from digestion, and that's your chylomicrons. We talked about this, and the chylomicrons are dropped into the lymph and then go into the blood, and in order to drop them off, we need, again, that ApoB48. Once it is in circulation, it bumps into HDL. HDL is that carrier of all those other C2 and E. Once it picks up ApoE and ApoC2, the C2 goes to activate LPL, and that cuts chylomicrons. So say they're giant molecules like this, and then over a course of time, they're floating around past muscle cells and everything like that, and then we have this little remaining saggy, wrinkled chylomicron remnant, because we've cut all the fats out of the middle here, and now we're left with this little saggy sac, okay, and that's your chylomicron remnant. In order to activate the enzyme that kind of came into play here, we need the C2, and that cuts the fats out of here, and then we're left with this remnant. Now this remnant has ApoE on it, and this can go for entrance, E for entrance into the liver and get brought up into the liver. And that's what our chylomicron remnant does. But in the process of getting back to the liver, it drops off C2 back to HDL, and then it enters. So remember, this is the first guy. It's also the largest. The second molecule is very low density lipoprotein, or VLDL. And the liver takes the chylomicrons up and free fatty acids that have been flowing around in the blood, IDL and LDL, everything's kind of getting absorbed, and we're now in the central location of our hepatocyte, or our liver cell. And we reform a big package, lots of tags, and a little bit of cholesterol. And this is known as your VLDL molecule. We can also take and form lipids from, if you have maybe a high sugar diet or a carbohydrate diet, we're going to have lots of energy that then we can push into lipogenesis from those carbons. And then all that can be packaged into this VLDL molecule. Now VLDL can't get out. We make it, but it can't get out unless it has the entrance or the exit code, which is your ApoB100. Once it has that on its surface, it's allowed to be secreted out into the blood and go around to the peripheral tissues to supply fats for those tissues, or to supply adipocytes for storage. And so on its way around to the tissues, it bumps into good old HDL, and gets two passcodes, the ApoE for eventual reuptake and ApoC2 as far as activation of that enzyme. Remember, that activates LPL, lipoprotein lipase. And so once it activates that, it cuts those tags, and eventually we cut it into a smaller molecule, which we're going to talk about next, IDL. So again, the order, chylomicrons, VLDL, and then now we're on to our intermediate density lipoprotein known as IDL. So once VLDL is cleaved into this IDL, this intermediate, and now has kind of an equal balance ratio of tags and cholesterol, then we can call it an intermediate. This molecule has ApoC2 because VLDL picked it up for it and then got cut a little bit smaller. Or ApoB100 because VLDL had that on it originally and became IDL. And then ApoE, which also was picked up from HDL in the process of coming out to the periphery. And so with these molecules, about half of our IDL that gets made gets uptaken into the liver, and in order for an IDL molecule to get uptaken, you need ApoE. ApoE is the entrance for IDL, and it is the entrance for chylomicrons. So please keep that in mind, okay? We'll be coming back to that when we get to some of the diseases. So once it gets uptaken, again, it can be repackaged as VLDL or be secreted maybe in bile or something like that, the cholesterol at least, and then it loses its E and C2, and then B100 is lost first as well. So the remaining 50% that didn't get uptaken in the liver will continue to be cleaved of its tags and form into a smaller molecule known as LDL. And again, that uses that ApoC2 for activation of that LPL. So now on to LDL, or low density lipoprotein. This is the next molecule. It's cleaved smaller from IDL, and this guy actually can be uptaken from cells in the periphery or from the liver, and that's via specifically LDL receptors. And in order for these lipoproteins, LDL, and the LDL receptors to kind of work together and say, okay, I need to be brought into the cell, it requires a key, and this key is B100. Remember where we got that? VLDL was initially secreted and had to be packaged with B100 in order to be secreted. This then allows the further step down process, once we get to LDL, that it allows it for uptake. And so that's where that comes into play. And so this LDL can be absorbed into other cells if they need cholesterol and stuff like that. And remember, LDL is that lousy lipoprotein, and it can be oxidized. If it gets oxidized to by reactive oxygen species, then what can happen is it can go in past your endothelial, like into the subendothelial collagen and stuff like that, into that space, and cause a little bit of inflammation. And that inflammation causes macrophages, which are some of your immune cells, to respond and eat it all up. But however, when it goes to eat it up, it can break it down. It's great. That's something that our macrophages can do. However, there is a scavenger receptor on our macrophages that LDL also can bind and enter in. And this is an unregulated process that our macrophages can't control. And so all this LDL kind of gets sucked up into them and makes them all really bloated and foamy. And these are known as foam cells. And we'll be describing that a little bit later. However, this reactive oxygen species comes into play because just think of someone that smokes a lot. They're creating a lot of reactive oxygen species for themselves to the point that it overloads their antioxidants. Say if they're taking in vitamin E or vitamin C, those antioxidants, those guys get rid of reactive oxygen species. But if you smoke a lot, you're giving your body too many. And at that point, we're increasing oxidizing of our LDL, and that could lead to increased risk of atherosclerosis. As to why people that smoke are pretty much directly associated with atherosclerosis. So that's something as doctors we need to be keeping aware of with patients that are smoking, that we make sure that they're taking in antioxidants and hopefully quitting smoking. That's something we need to counsel them on. So here's the kind of the process, everything that's flowing around. So let's describe this a little bit, okay? So here we have our peripheral cells, we have our muscle and our adipocytes, and we have a subendothelial collagen area, or in the intima of our blood vessels, and then we have our liver. So what happens is in our GI tract, we have chylomicrons that come via the blood. They get cleaved into smaller molecules, our remnants, and they get uptaken into our liver. And once they're in our liver, they get repackaged, our free fatty acids that we synthesize, our tags, we make tags, and then we store them as VLDL. And in order for VLDL to actually exit out, we need ApoB100, B100. Okay, so ApoB100 lets VLDL be secreted, and that goes out to the periphery that has, like muscle or adipocytes, that has this enzyme known as LPL, lipoprotein lipase. This cuts VLDL, requires C2 for activation, into free fatty acids and glycerol that gets secreted and absorbed into the muscle and adipocytes. At the same time, we've cleaved VLDL into a smaller particle known as IDL. Like I said, IDL has ApoE protein on it, which allows it binding once it gets into the liver for uptake. That can be broken into these molecules, and then they can circulate and come back into this process to go back out. So this can be a cycle here that's continuous. However, IDL doesn't have to always be absorbed using that ApoE protein. What it can do is it continues to go out into the periphery. And what it can do is actually can get to hepatic tag lipase or lipoprotein lipase. They're two different things. This one is actually found in the liver, but you can also find LPL. And activation from C2 allows for IDL to be cut into a smaller particle known as LDL. And this gives off free fatty acids and your glycerols and such, just makes it a little bit smaller. And now we have this LDL particle. And the LDL particle can be uptaken from peripheral cells in order for them to absorb cholesterol, amino acids, free fatty acids, and glycerol and everything like that. Those can all come from your LDL particle. They're all kind of stored within there. And that's your peripheral cells. Or what it can do is it can leak out and become oxidized LDL, gets uptaken from macrophages and becomes a foam cell. This can lead to atherosclerosis, which is this guy here. Or one last resort is our special receptors also going to be found on the liver. And this can be your LDL receptor, which your LDL receptor was also here, but your LDL receptor is also found on the liver. And this responds and needs a key entrance code, and that is your ApoB100. Remember, B100 was for secretion, and ApoB100 was for uptake in the liver and your peripheral cells, and that is your LDL receptor. And so this LDL gets reabsorbed, broken down into these guys, and then completes the cycle, and then it can continue over and over and over. So the only new fat or lipids that come in is via chylomicrons and absorption, or from sugar synthesis, because our glucose and everything like this can actually come into play to make free fatty acids that can be synthesized. But those are pretty much the only way that we can build fats is via glucose or via actual absorption straight up of fats. And that is your cycle of your endogenous lipoprotein transport. So onto a little bit of our high density lipoprotein. So I wanted to separate this guy because I wanted to make sure you had a little bit of time to absorb what's happening in your bad, well, I mean, they are not that bad. They're actually good. You need those fats, but the ones that aren't really great when they're in excess. But this one actually is really good when it is in quite high amounts. Not severely high, but some high amounts. It actually is good. And so HDL, or your healthy density lipoprotein, is ApoC2, ApoE carrier, and that gives it to chylomicrons and VLDL, and they can continue with their cycle. This guy, HDL, actually carries its own little apoprotein. This is known as ApoA1, and this activates a very important enzyme known as LCAT. We'll be describing exactly where that comes into play. So it also transports cholesterol, but it doesn't transport it just in like free cholesterol. It actually transports it as cholesterol esters. And these guys are pretty much kind of what I want to describe down here with this little Merlin guy. But pretty much what this is a cholesterol molecule kind of packaged and shrunk even smaller. It's kind of packaged not in its big, long structure, but actually is structured a little bit smaller, so you can package a lot more into an HDL particle. And then it takes those cholesterol esters back to the liver from atherosclerotic plaques and tissues. In order for cholesterol to come out of tissues, it needs to be kind of spit out of those tissues, and that requires a transporter known as ABCA1 transporter. Pretty much what it does is it pushes free cholesterol out of the cells, and then that free cholesterol undergoes a reaction that esterifies it and gets it into HDL. And that enzyme is known as lecithin cholesterol acyltransferase, or LCAT. So this is the blood. It's found in the blood. It's floating all around, and it actually makes those cholesterol esters from cholesterol. So this is that Merlin. So he's the guy that's making all this stuff. So here's our cholesterol kind of coming in this way, and he's actually esterifying it. He's kind of the LCAT of this guy. Esterifies it and makes them into a lot smaller particles so that they can fit into this HDL particle, which is the little suitcase that he's got. And so that's exactly what our LCAT does. ABC transporter is the guy that spits the initial cholesterol out. The LCAT is the one that makes it into esters so that we can get that into and package into your HDL particle. And so the order of what it goes is we have our discoidal, which is our HDL without cholesterol in it. Then we have our HDL3, which has some amount, and then HDL2, which has a lot. So this is the HDL2 is the biggest guy, and so because HDL is going in the reverse transport, the numbers for these guys actually go in reverse order. So 3 is actually the one that's actually smaller, discoidal is the smallest, and then 2 is actually the larger. We're actually going down in number. So here we have our HDL and reverse transport. And what this does is it actually, it starts off over here with our discoidal nascent HDL, and it's got its little ApoA1. And this HDL, what happens is it kind of passes by our peripheral cells that have this ABCA1 transporter. It spits out, this is the transporter that spits out free cholesterol, and then that undergoes our LCAT enzyme reaction, and this is activated from your ApoA1 protein. And this LCAT converts cholesterol into cholesterol esters, and those are stored in our nascent discoidal HDL particle. And that has now become an HDL3. And now this is what we would call kind of a basic HDL particle. And so HDL continues through this process, and free cholesterol gets spit out from this transporter, changed into cholesterol esters from your LCAT, and now we've become a large HDL2 particle. Now, pretty much this molecule wants to go back to the liver and drop off all the cholesterol esters it's picked up, but on the way it actually bumps into a VLDL particle. And so what happens here is there's this enzyme known as cholesterol ester transfer protein, or CETP, and this is found in the blood. And what happens is it takes some of the cholesterol esters from HDL and it puts them into VLDL, as at the same time it takes tags from the VLDL and makes it back into the HDL particle. So tags continue from VLDL into here, and then cholesterol esters go into VLDL. And at this point, this is the enzyme that does that CETP, and now our HDL molecule makes its way to the liver, bumps into the hepatic cells via the SRB1, or scavenger receptor B1, and it squirts out all its esters that it has here, makes it pretty much empty, and then continues back out in the blood, and now we have a discoidal nascent HDL. So it kind of wrings it out like a sponge. So once this SRB1 is bound in the hepatocytes, our HDL kind of wrings itself out like a sponge, and now it's a dry sponge and continues out here to go absorb more of this. And so that is your HDL and reverse transport. So now on to a little bit more of our clinical stuff. So I wanted to talk about atherosclerosis and how it happens. So we have our LDL particles, which came after IDL, which came after VLDL. And our LDL molecules actually can get oxidized into oxy-LDL. Now, like I was saying before, our macrophages usually have a mouth right here. And what happens with this is usually uptakes and eats a bunch of stuff, and then controls and degrades it. However, it also has this scavenger receptor A receptor on it. And what happens is this oxidized LDL binds and gets brought into this cell, and it gets absorbed so much in this that it becomes a foamy cell, and that's what we call a foamy cell. It's just a lipid-laden macrophage pretty much. And so what happens to these guys because LDL actually came into this location here, our macrophages sucked them up, made foam, and now there's so many of these kind of under this tissue. What happens is it leads to what is known as an atherosclerotic plaque. And so our atherosclerotic plaque is made of a bunch of these foam cells, and some of the actual muscle cells absorb some of the fats as well. So I'll kind of draw some of these guys with some fats, and that is where we get atherosclerosis. HDL could come along and absorb actually the fat from our macrophages and foam cells that actually can reduce some of the plaques that we do form. If those plaques get calcified, the HDL isn't going to help. And so that's why you kind of want to catch atherosclerosis early, so we can make sure we can bump up their HDL so we can help these patients. So now on a little bit further clinical. So measuring these lipids, this mathematical equation is actually really important for you to know and be able to calculate. They'll give you a basic just number. They'll give you, oh, we have someone's total cholesterol and HDL, and then we'll say, oh, their VLDL is this. What is their LDL? And you have to remember this kind of rule of thumb, that after someone has been fasting for like 6 or 7 hours, we do this test. And this is where we get all these levels, right? Other than LDL, we get cholesterol, we get our HDL, and we can measure our VLDL, and then we can back calculate to LDL. And so pretty much what we do is our VLDL is equal to tags divided by 5. And when you take that, pretty much accounts to how much cholesterol is found within our VLDL particles. And then you add that to HDLs, and then you subtract that from total cholesterol, and that will lead to our remaining LDL.
Med School Tutor!
You're at SGU, and you're thinking about Step 1. There are so many resources and so many opinions. How do you know which path to take? You've worked so hard, and you deserve to match into the specialty of your dreams. Med School Tutors has helped nearly 1,000 SGU students get their best scores on their CBSE and USMLEs through highly personalized one-on-one tutoring and individualized advice. Our SGU students see average Step 1 score increases of over 30 points when working with us. Scores that are their tickets to competitive residency spots around the country. Schedule your free phone consult today to be matched with your tutor. Med School Tutors. Get where you want to go.